educational purposes. So yes, we can start now. Ofer, it's all yours. Thank you.
Thank you, Daniela.
You're welcome.
Hello, everybody. I can tell you that it is quite confusing to talk to people which I don't see them. And there are still some people who are talking to live microphones. Daniela.
Yes, I am taking care. Please, everyone, kindly mute your microphones. Thank you.
Okay, and there is an echo. I don't know why. Anyhow, the world is going through an unusual period. And of course, at least in Israel, we in the last 7 or 8 weeks, we didn't have any chance to work, only on emergencies. And maybe the situation in your country is quite well, and we are looking the way to go back to full practice. But still in Israel, some people are afraid of going out, as if really a pandemic is taking place. Anyhow, it's a matter of time, and I hope that everything will come back to normal life. So let me start by introducing it, splitting the alveolar ridge to improve the horizontal dimension in order to put implants in. What happened?
Yes, I don't know what really happened. Apparently someone took over. Ofer, could you please again try to share your screen?
Yeah.
And please, I kindly ask again to all the participants, mute your phones, mute your cameras, and please do not try to share any content while we are doing this webinar. So Ofer, what you can do now is go again to do share and share your desktop again, please.
Yeah, I'm here. I don't know what happened.
All right. Yes, now we can see your screen again. That's
right.
Perfect.
Okay, so the subject has been introduced, and let me just go quickly into it. So the principle of GBR, we all know. This is a membrane, could be resorbable or non-resorbable. And what happened with such a wound healing without a membrane? You see that the bottom of this socket, there is bone, and the upper one, in the upper part, there is nothing, just connective tissue. So of course, if you want to have 100% of the place bone, we need to cover it with some barrier in order to allow bone to grow. Now, if we go back into history and we want to look when did it begin? The selective population of cells, we go back to 1956. I'm sure that most of you were not born. And it was first described by people who dealt with non-union of neurons. And as you can see, they actually applied membranes over nerves, and they got new nerves in between the two edges, which were covered by a membrane. If we go back into the history of bone, we see that at the beginning of 1959, it was first used they used a membrane to allow bone growth, and the first dentist to do it was Bowen in 1974, in which he restored deficient edentulous ridges by bone grafting. This just to pay tribute to the pioneers who understood something which is very popular and commonly used by us dentists in our routine base. Now, I want to talk a little bit about barriers, because we did some studies also in our department, published an article in 2004, and we wanted to see, is there a difference in the incidence of exposure of collagen membranes, those who were cross-linked and those who were not cross-linked? And our cross-linked membrane are resistant to degradation when exposed to the oral cavity. And if it is exposed and covered, is it possible that granulation tissue will cover the exposed collagen membranes? So we did a study, we published it in 2008, And as the purpose was to compare the incidence of perforation, and since we took biopsies, we wanted to see what is the verdict or what happens with the exposed membrane. So what you see here, this is a cross-linked membrane, and this is a non-cross-linked membrane. You see the different layers of a cross-linked membrane, and here you see some kind of arrangement of the non-cross-linked membrane. The study design was in 56 GBR sites in 52 patients. In 26 we used cross-linked, in 26 we used a non-cross-linked. And after 6 months we placed implants and we took biopsies from 36 cases, 18 from a cross-linked. Out of the 18, 9 were perforated and none were not perforated. And out of the 18 cases of the non-cross-linked, 6 were perforated and 12 were not perforated. Let's look shortly, briefly into one case that we did. We actually had to extract a cracked tooth. This is after the flap elevation, and you see the crack here in this area. And after removing the tooth, you see a typical dehiscence in which we had to graft bone and cover it, in this case, with a cross-linked membrane. 6 months after, we took biopsies from this case, one from here and one from here. And you can see after removing the biopsy with a punch, we have installed 2 implants, and this was a non-perforated case. This case, the one that you see here, is again a cracked tooth that was removed. You see that this typical buccal dehiscence. After suturing the area with what seems to be with a lot of tension, you see the bleaching of the soft tissue. Of course, we got a perforated area, and we took biopsies from this area. And let me just describe you shortly what we see. This is a close-up of the biopsy after being removed by a punch, and this is the histology. And just to briefly describe you this, as I said, 52 cases were used in the study. 33 were not exposed, 19 were exposed. Out of them, 13 were exposed in the case that we used a cross-linked membrane, and 6 were in a non-crossed linked membrane. And what we saw in the cases that we didn't find perforation, we saw that part of the membranes that were cross-linked, we noticed some ossification. And this is the typical non-perforated, non-cross-linked, and as expected, after 6 months, we see no, maybe just small remainings of the collagen membrane. You can see it here, this area, which is actually being in the process of being degraded by macrophages. And in a non-cross-linked, non-perforated cross-linked, we see the membrane always completely stayed in place. As we know, if the one who used a non-cross-linked membrane, you see the membrane. If you raise a flap, you still see the membrane. And as you can see in this biopsy, you can still see it. Now, what happens in the case that a cross-linked membrane was perforated? As to the question, does the membrane itself is covered by epithelium? This here on the right, you see remaining of the cross-linked membrane. And in this area, which is the center of the perforation, you don't see it. It means that first, this cross-linked membrane was first resorbed by the collagenases of the oral bacteria, and only then the wound was closed. you can see here the retipeg here and the retipeg here, which actually first the epithelium from this side crawled over here, and only after degradation it could bridge the cap to the other side of the perforation. I hope that you understand my English. I'm doing my best anyhow. So histology shows the truth. It is not a belief, it is the fact itself. Again, 3 months perforation, you can see how long the retipeg here. It means that the epithelium from here is traveling a long way until it is possible to bridge over a fibrin layer, and which creates itself only after there is a full degradation of the area that needs to be covered. So you can see here a long retipeg, and here is the remaining of a long retipeg. This is after 3 months. דניאלה, זה לא מתקדם לי.
Yes, we are seeing your presentation, Ofer.
Yeah, but I cannot.
Okay, I see that there is someone that is requesting control. Please, Ofer, can you deny it? You can see on the top of your screen.
Deny.
Yes, please.
Not stop presenting.
No, deny. Deny.
I don't see the denial. Where is it?
Okay, I think now you are okay. You can try to move forward with your presentation, please.
I cannot control the computer because somebody is taking control.
Okay, so please try to stop presenting and present again. Excuse me, Ofer. Everyone, please, again, I would like to remark, don't try to put a presentation while the speaker is talking, because we're having this kind of delays in the flow of the presentation.
Okay.
All right, thank you.
So this is the case of the cross-linked. You see at the edge here, just a moment. You see at the edge a long retipeg, and in the center you see the healing that took place only after the remaining of the collagen membrane were removed by the macrophages. And after 6 months, of course, the retipeg is shortened. It looks well organized. And here in high magnification, you can see that on the edge, right under the edge of the perforation, you see the remaining of the cross-linked membrane. And here, a lot of rich connective tissue, rich with cells, which is actually what the base of the covering by the epithelium. Now, I will just go now into the subject that we actually are meeting, splitting the crest. So it appears in different names. Then if you look into the PubMed, it will have a lot of names. Could appear as an interpositional graft, as a split osteotomy of the alveolar ridge, or crest splitting for bone expansion. And we use it in order to enlarge horizontal dimension during or prior to implant placement, when ridge width is between 3 to 5 millimeters. And the insufficient width may lead to difficult to place an implant to use of 2 narrow implants, which does not fit or do not fit the function. Implants may lead to implant in extreme angulation, and sometimes implantation is impossible. The prosthetic could be very poor, might be unsatisfactory, may be due to lingual or palatinal implant position. Now, as to the PubMed, it could, as I said, it could be under the name horizontal augmentation GBR. There we see a lot of articles, 553. Under the name of ridge expansive osteotomy, we could find 82 articles. Under the name of only bone grafting, 356 articles. Split ridge technique with interpositional graft, something like 53 articles. with a ridge split technique without interpositional graft, 157 articles. When you use the keyword split crest technique, you can see you can have 89 articles, and with the key edentulous ridge expansion technique, we can see 54 articles. Now, one of the first people to introduce this technique was Massimo Simeone from Italy. He did a split crest causing a green stick fracture. In his case, in this study that he reports, he did a simultaneous placement. He used a Gore-Tex membrane, and he also took histology. This is Massimo Simeone. The second one is Scipione in 1994. He did a full split partial thickness flap, which I will introduce it to you in more details. He did an osseous incision in the mid-crest, distal and mesial, in order to allow movement of this piece of plate that he wanted to remove, to move. And the second stage in which he put an implant was 4 to 5 months after when he did this technique. This Simeone also reported in 1999 on 2 clinical cases, and he reported on high success rate, something like 98%. And this is actually photographs or photos which are taken by him, and I'm just showing what he showed. He put 3 implants and he took biopsy from this area, and he put it into a transmission electron microscopy. It is very interesting to see. If you see this black line, on the right side you see some stria. On the left side you don't see the stria. The right side is collagen membranes, collagen fibers, which are in the process of being mineralized. And on this side, you see mineralized collagen fibers. And the dark line is the phase between the non-mineralized and the mineralized. So you see the process still after 5 months of the replacement of soft tissue into osseous tissue. So let me go directly now into the description of the technique itself. By the way, I hope that those who do not do till now the split crest, I fully recommend to do it, because for me it really gives you bone, not like the other technique of when we do some lateral augmentation only with xenograft or allograft. Anyhow, as to the description of the technique, first we elevate either full thickness or partial thickness flap. I'm sorry. So what do you see? You see the bone. You see this side of the flap. This is a full thickness till this area. Then you pull the knife parallel between the flap and the bone, and you leave this periosteum over. So, because you are going to cover a narrow, you're going to cover a narrow bone, which becomes wider after the technique, you need flexibility of the soft tissue in order to fully cover it. So you do a full, and from this area, you are splitting this area of mucosa, and you leave this kind of periosteum which is attached to the bone. It has two targets. One, to allow the movement of this soft tissue. A second, the nourishment of bone, nourishment of blood to the bone given by the remaining periosteum. And clinically, it looks this way. This is the denuded bone, and here Down here, you see the periosteum. Maybe in the next slide you will see, yes, here you can see better. This is the bone, and above 4 millimeters down, you see this thick tissue, which is the periosteum with a little bit of connective tissue over it. And this will allow two things. One, as I said, the nourishment of bone by the periosteum and the flexibility of the flap in order to cover a larger dimension, horizontal dimension of the new bone. So this was the first stage. As to the second stage, now we have to go into the bone, and it should be in the center of the bone, or if we choose to move, we will choose the thicker part of the remaining bone, which is going to be steady in the place. This should be the thicker part of the bone, and the thinner part should be removed. Here you can see a place that we use a piezoelectric tool in order to split the bone. Generally speaking, I prefer to use a piezoelectric and not a rotating tool because it's much more safer to do it. Here, this is an anterior mandibular area. We do the same, we use the same instrument. As you can see here, the marcation of different depth. We usually, when we do such a split, we go into the incision, the osseous incision, to the needed length of the implant that we plan to put. And this is the piezo, which is cutting through a dense bone, which is the most dense bone in the mouth. And this is after the use of this osseous incision. You can notice here 1 hole, 2 hole, and 3 hole. This is, we use this marcation if we want to put implant simultaneously with a split crest technique. This is because after the implant is needed to be placed, this will guide the implant exactly into this area. But wait, maybe till now it is not clear enough, but with the time it will be more clear. So the second stage was the incision of the bone, the incision of the bone by piezoelectric. Now, in order to enlarge this split crest, usually we use a chisel or another osteotome in order to widen the distance between the two plates. And this is a site that exists on the maxilla. In this area, that we did it on the maxilla. This is in the mandible. You cannot widen in the mandible without doing two vertical osseous incision, because it is very, very dense. So in this area, most of the cases we have to use a vertical vertical osseous incision. Also in cases in the maxilla, in this area, this is an occlusal view of a vertical incision and also a vertical incision. This is a central vertical incision, and here also. As you can see here, after performing the osseous split, sometimes you can use an osteotome just to screw it in, and because this is wider than the width of the incision, then the buccal plate will move buccally. The same was performed here, a mid-crestal incision and 2 vertical incision, which allowed to move buccally the buccal plate. And later on you will see what we did. Till now, what we did is 3 things. 1, flap elevation. 2, we did the osseous incision, and we actually opened the gap by osteotomy or a chisel. Stage number 4, we graft bone by using, or we push the, or we push the bone into the area with a graft. I'm sorry, I mixed up in a little bit. We can use, you can maintain the gap with or without an implant. The first cases, the gap is maintained by installing the implant. So that's how the two plates are held apart, as you can see in this place, in this side, and also in this side. In this case, some problem occurred, and we had to wire the two plates together with a sterile orthodontic wire. You don't have to use more than that, in order to keep the two plates in place without losing it into the soft tissue. The case that you showed before, in this case, we did not put an implant simultaneously. After pushing apart the buccal plate, we put some graft into this area in order to go back in few months and to put the implants, as you will see. In this case, two implants were holding the two plates apart, and then it was completed by bone grafting. And this case which you showed, which you saw before, you can see this spike of bone. Do not remove it. Why? Because later you can graft bone in this area, and when you cover it with a collagen membrane, you will have a wider ridge. As you can see here, we grafted bone here, we grafted bone here, and that gives us the potential to gain a wider ridge. And this is the case that you showed before, which we had to wire the two plates together, and we covered it, in this case, with an allograft. And before closing it, we did some periostal scratches in order to allow a closure without tension, tension-free closure. And after grafting bone, of course, we covered it with a membrane. In these cases, we are, as a routine, we prefer to use a resorbable membrane. And of course, to close it with a tension-free sutures, and trying to spare perforation of the soft tissue. Most of it is because we use too much tension to close the two flaps together. Now, I want to present you an interesting case. And this surgeon is a very brave one. And as you can see, he's using a rotating disc. This is a design of the plate before moving it. And actually, intentionally, he is breaking this plate and connecting it. After placing the implant, he connected it with a screw, graft bone, covered with collagen membrane, and suture it. I don't suggest you to do, in the first case, this technique, because it's unpredictable. You don't know what will come out of it. And let me just again stress it for you. Use a combination of full split thickness flap. The full should be the area that you put your sutures in, and the split thickness is the area usually in front of the mucosa, which will allow the mobility of the flap in order to close it without tension. And again, as you saw before, this is the area of the full thickness. Here you stop doing the full, and you start here the separation between the periosteum and the soft and the connective tissue of the flap. Beware not to make any perforation in this area, and this you can achieve just by putting your knife parallel to the mucosa, as you can see here. And if you keep it, then it will be okay with you. Here again, this is the periosteum, the remaining periosteum, which is part of the technique of the full partial thickness flap. Again, the case that you saw before, now the emphasis is more on the treatment of the soft tissue. You see the central split and the mesial and the distal vertical, which allow the movement of the plate back in the buccal direction. And these are the two implants in place. The bone looks okay. It's about 24 months follow this procedure. Now, as to the delayed expansion, it was described by Isolidis from the University of Vienna. It is very interesting. I tried it several times and it works. It goes like this. First, you design the crestal incision, the distal and the mesial incision, and also the apical incision. And you do a complete incision from all directions, but without removing the plate from its place. And you close the soft tissue for 40 days. After 40 days, by the way, this is the line of the incision on the upper left part of the screen, but we did not push this block outside. We just left here in place and we close immediately the place. Coming back after 40 days, what do you have after opening it? Actually, between our plate that was designed by, in that case, it was designed by the piezo, you have osteoid, all over osteoid. So just enough to put a small or a narrow chisel and you make a movement bucco-lingually, it will move away the buccal plate, because there is an osteoid and not a bone. So in this case, you can push away the buccal plate and install the implants. So biologically, it makes sense. And here you can see the implant in place. One may ask, how do you cover a larger volume? In this case, you scratch the lingual flap and you leave the buccal flap in place. And this is again. And this is the panoramic of the case. It works, believe me. I suggest you try to do it. It's very safe. Another case, it will just repeat itself, a very narrow. In this case, what I suggest is to cut this knife edge, and then you are exposed from the above. You can see the spongeous part, and into the spongeous part, you can more easily create the central gap between the two plates. And in this case, 4 weeks later, you go in and you put the two implants, you graft the bone, and then you can close it. To summarize, a delayed expansion enables good horizontal gain without fracture of the buccal plate. Since I don't have enough time, maybe I'll just show you some cases that we did. This is, by the way, another technique of enlarging the horizontal dimension is after you do the central incision in the ridge, you put this instrument and you gradually open it by using a screwdriver, which opened the bone by just opening the width between these two arms of this machine, as you can see here. And this is a clinical photograph of this technique. I do not suggest it because sometimes these tools are lost from its place, and usually it's quite painful for the patient. But I have to show you because it's another potential area, and also in this case, 2 implants were successfully were installed in this area. All right. Now, these are the two tools that we are using in most of the cases: the piezo tips and the osteotomes. The osteotomes are enabling us to very, very delicately enlarge the space between the 2 plates in order to allow to put the 2 implants in place, as you can see here. I do it very quickly because I hope that you are with me the way I think. Another interesting comparison was made between an autogenous interpositional graft versus an on-nail graft, and it went like this. They first, in one case, they split this ridge, and the other one, they have put an onlay block. They harvested it from the symphysis, and in one case, they have put in between these 2 plates, they have put the interpositional graft. You can see it here. The block that they harvested from the symphysis was put here, and it was tightened with a fixating screw. And so this is the interpositional graft. It's a split crest with an interpositional graft, autogenous interpositional graft. This area received an onlay graft. From the other side of the symphysis, a block was harvested and tightened onto this area. And this is the area after healing the onlay graft, and this is the area of the interpositional graft. And by the way, if you use an onlay graft, sometimes you get a perforation of the soft tissue and it becomes necrotic, which will not happen if you put it in an interpositional graft, just because there is a blood supply from 3 directions, from the lingual, from the buccal, and from the bottom part of the onlay graft. So 3 places are supplying this graft blood, allowing it a higher degree of staying alive, if I can say. And what they found, that there is a higher bone gain with an interpositional graft with less complications. It's very important. Now, let me just go quickly over it because we are lacking time. I want to go some full cases that we did. Let me just summarize this part of my seminar, a diagram of a split crest simultaneous implant placement. So as we said, before we split the crest and we want to put 2 implants here, first we markate the place of the planned implant. So first we do this. Then we do a split crest. Here is the marcation mark of the anterior implant. Then we go into with an osteotome. As I said, this is one of many tools that exist on the market. Here you can see the way it works. After completing pushing aside the two plates, you install the implant. This is the implant in place, and because we pushed only the corona part, there is a creation of a self-contained defect. Here we can graft bone and cover it with a membrane, as you can see here, and close it. Some clinical cases that were done in our department. This is anterior mandible. This area, the soft tissue doesn't really cover. They're not exposed. The problem here we plan to put 3 implants. This is the incision, the soft tissue incision that we use. We do a vertical because we are going to cover a wider bone. So we have to do a full partial thickness. And this is, here it's very narrow. So of course we have to expand the bone. We can use either lateral augmentation. In this case, we prefer to have a real bone. So we are splitting the crest here. As I told you, first we marcate the center of the future implants. We use the tips of the piezo surgery. We widen it very slowly, very delicately, and we drill to the maximum, to the needed maximum depth of the needed implant. We use several chisels. First, we begin with the thin, then we gradually go into wider. The same approach that we drill with the growing width of the diameter of the drill. We do the same with the chisel. We start with a narrow and we end up with a wide. As you can see here, again, this is the center of the future implants. 1, 2, 3. It really gives a good orientation where to put the implant if we want to take the simultaneous approach. It's really very, very helpful. And we show here the parallelism. Again, we push, and we ended up with 3 implants in place, grafting bone in between them. You don't have to graft bone. You can just cover it with a membrane. You don't have to graft bone. Of course, you feel better if you do graft bone, but you don't need it. We cover it with a membrane, and these are the 3 implants in place. Let me just go over quickly here. I use only ridge for splitting the ridge. I use only the piezo. It's safer. If I hit a blood vessel, nothing will happen to it. I hardly use I hardly face problem with severe bleeding during such surgeries. Let me just go quickly here because we are running out of time. This is after splitting the ridge, after installing the implant. Again, another case. After exposing it, it looks okay. Really, it's promising. And again, briefly, before splitting the crest, you marcate the center, you widen. You create the ridge, the split, you widen it, you put the implant with or without a grafting bone. Now let me show you quickly a case that was done by Dr. Ran Herzberg, Dr. Yaron Blasblag, and by myself from University of Tel Aviv. And this is a case, quite a severe case. It has many other problems. But just let me pull your attention to this area. We thought that if we put an implant here, the prosthetic part will not be satisfactory, and she wanted, after getting divorced, she wanted to have another appearance, and we have to respect her wish. So this is the panoramic before, quite a catastrophe. Before we started, you see two old implants here, but perfect, no problem. And this is the area that I'm going to discuss with you. Again, this is a close-up without the denture. You see there are some prosthetic problems. Since this is not my profession, I will not go into details. The photographs will speak for itself. I hope so. So, and this is from frontal view. You see the location of the lower crowns in comparison to the center of the ridge of the upper area in front of it. And Dr. Blasbar created the mock-up here. And here you can see something that she liked very much, but you see that the shape of this part of the crowns are not nice to her eyes, and she wanted us to push this area to the buccal area so that the final restoration will look like teeth. So we had to plan. And here you can see this temporary bridge in place, and you can see the problem that she didn't like. She wanted to have it as close as possible to restoration of a tooth. What you see here is a CT scan with the previous bridge in place. And of course, you see that the center of the implant will be something here, and here it will be the buccal part of the crown will be far away from the center of the implant. So I have to do something in order to correct it. And the something that we decided to do is to perform a split crest in this area. By the way, this is the surgical guide. Here you can see the distance between the center of the needed implant. It is outside of the bone envelope. So we have to bring the center more buccally. So we split the ridge with a piezo surgery knife. You see the ridge with the two verticals. After pushing aside with the chisel, this is the before and this is the after. This is about 8 millimeters here. And this is the surgical guide, and you can see the plate is touching the buccal margin, the gingival buccal margin of the guide. This is the before, and this is before closing the area. We have grafted bone in between the split, and this area is also something that we can use in order to enlarge the ridge, because this is a self-contained area. So we can graft bone in this area as well, covering it with a collagen membrane and suturing with a tension-free closure. And this is the follow-up. This is 2 weeks after. You can still hear the incision of the soft tissue. By the way, I can just tell you now, we did not graft enough. We had to graft it till here, but the prosthetic guy wanted us to maintain the papilla. That's why we didn't graft here bone. Later on, you will see that it created a problem. And this is a temporary after 3 months of healing. And we planned here 3 implants in this area. And when we went back, this is the width of bone that we earned here. Here, as I told you, we did a mistake. We didn't graft here. This is the soft tissue incision, and again, since this is a canine, he insisted us to maintain the papilla. We didn't argue. This is the 3 implants in place. accordingly to the surgical plate. And these are the 3 implants with the healing cap, and this is with a temporary bridge in place. This is the follow-up 2 weeks, 1 month, and 2 months healing. It looks nice, but here we knew that there is a problem. This is the before, and this is the after. This is the before, and this is with the after. I think one can argue if it is justified to maintain to do so many surgeries, but it was the wish of the patient, and we had to respect it. So in such a case, usually we supply the patient with a bite guard, and she's very happy here. Just remember how she looked before. This is the before, and this is the after. I think the Dr. Blasberg and Dr. Herzberg did a fantastic work, but it took us around 2 years to complete all the treatment in this case. And of course, we don't let them go home without showing them how to clean their prosthetic, because after putting so much effort to build up back or to reconstruct her mouth, she had to prove that she deserved it. And I think that I will give you time for question if needed, because the next case looks exactly the same. Danila.
Yes, thank you so much for your presentation. It was a really good presentation. Now we have space for questions. So everyone who wants to ask a question can write now in the chat. And you're welcome to ask with microphones.
Show conversation. Okay.
All right, so if you have any questions, please feel free to write on the chat. And in the meantime, we thank you, Ofer, for the extremely good presentation that you just gave us, very informative.
I do urge you to use the technique because it really creates the real bone that we are looking for.
All right, I see we don't have any questions. Okay, here we have Dan Moraris asking, did you try open healing after bone split?
Did I try to open healing? I don't understand the question. If I try to take a biopsy? Dr.
Dan, maybe you can clarify. Dr. Dan Morari, you can clarify your question, please.
I don't understand the question. Not covering the membrane. No, I didn't try. I use only membranes for that. Now I understand. Dr. Morar, I always use a membrane. Okay. He got the answer. Case of buccal lamina fracture, can you fixate it with a... No, it's not enough. To use it only with the suture, it's not enough. You have to fixate the bone. But it's not a problem. Either you use a fixating screw or an orthodontic wire. You got the question. You got the answer. What about? I don't know them. Dr. Morar. I'm not acquainted with the Nash burrs. Sorry, I'm not acquainted. Do you recommend the split alveolar ridge technique instead of Hui technique for horizontal augmentation? In my hands, it is safer because Dr. Hui technique actually it's a small only graft. So I always prefer split. Always. Theodora, yeah. Thank you. Thank you also. After how long time you put definitive prosthetic? Oh, it's the same like maybe it could be a shorter time. 3 months is enough. Andrik Dragan joined the meeting. Okay, welcome.
All right. So if we have any more questions, doctors, please feel free to write in the chat. Here we have one more. All right, so there's Dr. Yes.
Regarding bone width. Oh, very good. You need to have at least 3 millimeters. I don't know who is asking it. It's an A. It's a big A. So you need to have at least three. In order to use a piezo, you need to have 3 millimeters. There is another tool called magnetic mallet, where 2 millimeters are the minimum that you can use it. Magnetic mallet works in another way, but actually the principle is that actually it goes into the bone but you don't lose bone. In the piezo, in order to cut, you lose a little bit of bone. That's why you need to have 3 millimeters. But if you're using a magnetic mallet, you can look for it in the YouTube. There are some good videos. Then 2 millimeters is you can do a split in 2 millimeter width. But with the piezo, it's at least 3. Okay. Thank you also. Can you? No, don't use. There's a question of splitting the crest with sinus. Don't do it. Don't do it because you may be left with a wall in your hands. Don't do it. It's too much. Either you do it before the sinus or after the sinus. I recommend you to do it after the healing of the sinus floor, not before. Be my guest. You are welcome. Any more questions? תודה רבה, סמואל אמה. Hope to see you in Paris, Samuel. Okay.
All right. Excellent.
Yeah. Do you split technique without using xenograft? Yes, you can put allograft, or you don't have to put any graft. But then you have to put the implant because something have to hold the place apart from each other. So either you put a graft that will hold it with a graft, or if you put an implant, you don't have to put a graft, but you have to cover it with a membrane. Okay, Daniela?
Excellent. Excellent. Ofer, thank you so much for your time. Thank you everyone for attending this session. It was very interactive at the end with very much questions, interesting questions. So we hope to see you everyone in our next webinars. Stay tuned. We are publishing in Facebook all the updates of upcoming webinars. And a special thank you to Professor Moses for this interactive lecture.
All right. Bye-bye.
Thank you. Goodbye.